right, well, I think the appointed time is here. We don't want to steal any time from our discussion of this really important topic today. So welcome officially to our 17th webinar. Time's flown. So our first webinar was in February of 2019, and we're up to number 17. And this is our first time doing a panel discussion. So I'm delighted in a second to introduce you to our dynamic panelists, all of whom have some real expertise to share specifically about speech. We're glad that you've joined us today. And so Niti, we can go to the next slide as we try to manage the technology across many continents. Please, if you can, change your username on your screen. As I shared a second ago, if you click the top right-hand corner of your own box, there's 3 little dots there, and if you click that, it will allow you to rename yourself. So if you don't have a personal name there, it'd be great so we know who we're speaking with. We'll ask you to keep your microphone on mute at this point until we get into the discussion part. And at that point, it'll be lovely to hear and see from as many people as possible. If you're organizing your screen, everything on Zoom is customizable. So you can drag the comment box over. There's a chat feature that would be great, very helpful to have open so you can see, and if you have any questions along the way or comments along the way, that would be great. And even, I mean, this is a newer feature, but if you are agreeing with something or you want to encourage someone along the way, there's even a reaction button. So as you can see there on mine, you can give someone a little thumbs up. It does disappear on its own, but we'll want to make this as interactive as possible. So welcome, and do feel free to explore Zoom as we go. And we'll at my college there. So our agenda today, we'll do a quick update on the Circle of Cleft Professionals, especially for those of you for whom this is your first meeting. We're glad you're here. We'll have a presentation and panel discussion, and we'll have obviously one of the features of the Circle of Cleft Professionals webinars is this chance to discuss. So don't just save up your questions. If you want to post them along the way in the chat, that'd be great. And then we'll have a chance to ask the panel or ask other people on this call how they are managing some of these speech requirements during this COVID era. And then we're very excited about our next webinar also in July. Some of you will know Dr. Christy McKinney from Seattle, who will present on planning a research project. So make sure you write that down. And as always, we commit that you'll be done within 60 minutes, so we won't run over time. You'll be able to get back to the rest of your day, but we're really delighted that you've carved out some time to spend on this capacity building discussion today. So if this is your first time with the Circle of Cleft Professionals, or COCP, again, our goal is to facilitate this type of collaboration and networking, to talk about the impact and learning that's happening in CCC projects, and really our focus is on supporting local teams in low and middle income countries as they implement comprehensive cleft care. And we've been growing. I don't know, Niti, do you want to take us through the next few slides?
Sure. So we now have 232 members in our COCP community, belonging to 12 plus specialties within cleft care, coming from 41 different countries across 5 continents. You can see that a majority of our members are speech therapists, surgeons, cleft charity leaders, and orthodontists. But you can also see that we have representation of members from across all other specialties within cleft care, such as nutritionists, social workers, and nurses, which brings in a large range of CCC experience to the COCP. So yeah, these are the 41 countries that all of our members come from. The ones in green are the countries that we have the most membership from. And they're always looking at growing our community. So if you know someone who might benefit from or would be interested in joining the COCP, please invite them to apply for membership through our website. We would like to thank our 10 charity organizations from around the world who are invested in supporting comprehensive cleft care in low and middle income countries. And all of you as COCP members would have received a survey email. Your feedback is really, really important to us. So please do fill out that survey at the earliest. We've extended the deadline for this to 5th July. I'll now invite you to introduce our 3 panelists from across 3 different continents.
Thanks, Niti. And Niti is my colleague in Toronto, the global, the manager for global initiatives for Transforming Faces as well. So welcome everybody. And we'll come back to that survey before the end. If you have not filled it out, it looks like for the average, it takes about 5 to 6 minutes. So not a huge investment, but really that data will be very important to all of the NGO sponsors of the Circle of Cleft Professionals as we think about how we can best support you in the coming months as we deal with this COVID crisis. But as I mentioned off the top, this is our very first panel discussion. This emerged from feedback with many of you about what you'd like to see. And so we're delighted to start with our first time of having 3 different intrepid leaders in comprehensive cleft care, all with a speech focus, who can present a little bit of a snapshot of what's happening in their particular regions, as Niti mentioned, in 3 different continents, and then to carve out quite a bit of time for discussion, for questions, for feedback, for other resources that can come from the community. So without further ado, I'll introduce our first guest, Suraj, Dr. Subramaniyan from Chennai. He's an associate professor in the Department of Speech, Language, and Hearing Sciences at SRIHER, or Sri Ramachandra, and is a leader of the CCC team there. He's also a Smile Train partner and a Transforming Faces partner. So we're delighted to hear from Dr. Subramaniyan this morning.
Hi.
Suraj, over to
Thank
you.
So much. Thank you. I'm Suraj. Thanks you for the introduction. So I represent Sri Ramachandra Cleft and Craniofacial Center. And as he said, thanks to Smile Train and Transforming Faces for providing me so much opportunity to be what I am today in cleft care. So I am representing the community project, which is supported by Transforming Faces. And I lead the project, and under the guidance of Professor Rupa. She's the person who instrumental in bringing this project in 2005. And I have a fantastic team. I will talk about them at the end of the slide. Niti, next slide, please.
Sorry.
Okay. So this is the project which I'm going to talk about. I'm going to talk about it in 2 parts: what is known and what is unknown. Okay. Our team is based in Chennai, which is in Tamil Nadu, and we work from a tertiary care hospital. And we have a terrific team to support and provide cleft care. From here, our vision was to provide cleft care services to remote parts in our region. So we identified 2 regions, which is 200 kilometers away from our tertiary care center. Minimum time taken is about 4 to 5 hours to reach the main cities in those 2 districts. Okay, so these are the 2 districts which I'm going to talk about in my presentation today: Tirunelveli and Kadalur. One is a coastal area and one is a hilly, dry region. Okay, next slide. Next, please, Niti. The previous one. We skipped a slide.
Yeah, I think there just takes a slight delay to get it viewed from everyone's screen. So yeah, thanks for bearing with us as we work through the remote slide advancing. Thanks, Suraj.
Just to give you a snapshot of the region where we are working, I am not working, and my team is not working in a place where the resources are available in plenty. I'm working in a place where the resources are challenged. To identify a resource and take the resource and provide service is a big challenge. So it's a predominantly, one is a coastal and fishing related activities which happens, and another is a farming based district which happens. So these are the 2 districts we work with. In put together in these 2 districts, we have about 200 plus active beneficiaries who receive speech, hearing, dental, and surgical services from. So in my presentation, I'm going to restrict my talk about speech activities and what are all the services which we are doing. And I'm going to the known part, what we did from January 2020 to March 2020. Can you go to the next slide, please, Nathan? So between Jan and March, we have done a variety of activities. We have done multidisciplinary camps, 1 multidisciplinary camp, and then 4 speech camps, which we regularly do. And we had a lot of patients coming and seeing, and that's the last time we saw a inpatient visit and inpatient consultation. And since then, there is a lot of changes which I'm going to explain. The other services which we provided were, can you go to the next slide, please? speech and hearing assessment camps, a community-based intervention, and then we also provided a lot of community engagement activities. You can go to the next slide, please, Neeti. So in the community engagement activities, we work with the families, provide them field visits. The next one, we provide them support in the district, and then we engage with the grassroots level workers in the district and provide them guidance in identifying cleft patients, and if they identify a cleft patient, what they should do. These are all the known part which we are doing effectively from 2005 till March 2020. And we never felt that we will have to change our entire process of networking, continuing to provide services. So the 15 years of experience was turned in a minute in March 28 when the lockdown was announced and when the pandemic was declared. And there was a point that the physical in-person visit with the patient is no more possible for time, whatever it is. Okay, so the only one weapon which we had in our team was, next slide, was we had tested tele as a model of providing services. And I'm not going to declare that we were best in that. We had a lot of challenges. At least we felt happy that we started, but that was not enough. This is where the unknown unfolds. Can you go to the next slide, please? So March 20th or so, our country came into a complete lockdown, and we came to know that we cannot see our patients, but there is a commitment to provide services. The first thing which my team did was develop a quarantine work schedule for the core project team. I have a dedicated project SLP, Akhilan, who is working for me, and Gomati, a project admin who is working for me. So those two came up with the idea of how can we change the work pattern. So we had a meeting and then changed our work schedule to work from home and work for the community and work with the patient. And the next level of people whom we had with us were the community workers. They were all in the community, patients were in the community, but no one can see each other. So the distance between me and the patient was much more than the distance between the community worker and the patient. Though they lived 2 streets from where the patient was, they were not able to go and see. So we had to come up with new information. We spent about 20 days identifying and developing a database of who can we contact, whom we cannot contact. We had a list of 200 plus, but to our surprise, our list was filtered and we could reach to only 80 or 90 patients. I felt happy because something is better than nothing, and our team will be able to provide services. Next slide. But the challenge did not stop. Next level of challenge came. All the shops were closed. We cannot go anywhere. How are we going to provide service? So we empowered all our community workers. You take your papers, draw whatever you want, and then bring whatever pictures in your room, cut it. So we made it no cost work, because I cannot expect my worker to go by and I cannot expect them to spend. So they collected materials. If they were working with a child in the sound K, they collected all picturable things, or they started drawing. And we had to field test whether these all can be done. And this was done by Akhilan and Gomati, who were working with me while I was taking care of my online academic university programs. They were able to work on field and get all this information. It was very helpful. And there were some pictures which cannot be shown in the screen. So what they did, the community workers collected the utensils, all the vessels, whatever they have, which is matching the target zone, and they started using. So they had a session where they displayed the material and they wanted to see whether the child, where the SLP and the project admin on the other side, whether they are able to see. So this entire screening process alone took us about 15 to 20 days plus, identifying a database and developing a materials. Once we developed the materials, can you go to the next slide, please? So from May 1st, we had an active process of working. You can see the developed materials are being used in the therapy sessions now. We had recruited about 11 patients who were actively received services in the month of May. And then about 78 sessions of speech correction sessions are provided. And all the sessions, you see Akhilan monitoring the sessions and following up with the patients and working with them and giving them guidance. He has in person followed up 30 sessions of what is happening. and he allowed the other sessions to be remotely handled independently by the worker. So this is a new experience which we are learning. We really don't know whether this is what will work, but we have started working and coming up with an idea of how can we connect to the patient. So this is what we have done. But what are all the challenges which we have faced? Timings. Timings is a very big problem, because there are some places where the family members get out of the house for a small work, and there is only one person having an Android phone. Android phones, you have iPhones, Android phones, and non-iPhone and non-Android phones, where you cannot do any video call as such. So most of the families who got filtered out had only phones where they cannot do video call at all. The second set of families who had the phones where video call is possible, but they did not have the money to recharge for the mobile network, and they were not willing to go ahead, and they were willing to receive voice calls, but not willing to invest in the internet packages as such. So that was a very big challenge. So most of the sessions which carried out now started after 5 p.m. or 6 p.m., went on till 8 p.m., or started in the early morning where the family member on the phone was available. There was other problem, because all children are available in the community. Bringing them back to the session was very difficult. They went out and go and play. So bringing them back was very difficult. So that was another challenge which was possible. Another thing which you can see, there may be a child, there may be the Android phone, and there may be materials. But you can see in the screen, when we were doing a review, all three of us had a poor connection. So there was a lag. Whenever there is a lag, speech sessions cannot be conducted. So we have trained our workers also, when there is a lag, stop it and then go ahead. So there are many norms which we have relaxed. Provide 30 minutes continuously. You have to be very strict in documenting. So those are all the norms which I have relaxed, because if I have all the strict criteria, no session will happen in a remote places where the internet is challenged. So this is a learning phase. We are trying to work on this. So this is the unknown which we are trying to work and understand. There are many unknowns, like when will I go to the camp? If I go to the camp, will I have PPE? Is my patient educated about use of PPE? Is my patient educated about the respiratory etiquettes which are talked about? So those are all something which we are keeping in mind to talking to community and get them understand or follow all of that. So these are all the experiences which I want to cover in brief 5 minutes time, which we have, what we were doing, and then what happened. And then the only way to go forward is we have to innovate. And every day when we have meetings every week, we identify innovative practices, and we are ready to accept challenge and accept changes. Only if these two we are able to do, I'm very sure that we will be able to provide continuous service. And there have been requests from patients say that I really don't want to come on tele. I'm not happy. When the bus starts to come, when the transportation resumes, I will come and see you in person. Those patients, we don't trouble them. We wait for them. But we make sure that we go and call them at least once a month to see whether there is any small change in acceptance of teleservices as such. But we respect their decision and we follow. So these are all the things which we may have to do.
Thank you so much, Suraj.
The entire work is done by this team. So the credit goes to the community team and the team at Ramchandra who worked with me.
Excellent. There's so much. I know we're limiting you to this very quick summary, but that was super helpful. And I think your colleagues in Ethiopia are already chiming in saying, it's sparking these amazing ideas. So again, please, participants, please feel free to use the chat to identify things we might want to follow up on. But I do want to keep us moving through this panel so we can get a snapshot of 3 different contexts. So just take a second for yourself. Think about what questions or comments you have for Suraj, and then we'll move on. So I'm delighted to have Dr. Adeola Olusanya from Nigeria. She's the acting head of the Department of Oral and Maxillofacial Surgery at the University of Ibadan, a member of the CCC team at the University College Hospital, and she has a special interest in cleft speech. She's also a Smile Train partner, and we're delighted to have her with us today. So welcome, and please, over to you.
Yeah, thanks, Hugh. Thanks. I'm happy to be here. Adeola from UCH Ibadan, and I'm going to give a snapshot of what's happening in Ibadan based on speech therapy, how we've been able to do it. So I'm going to use this outline, what our team has been able to do before the COVID era, and then what we're doing currently now. Presently, we're still on lockdown, but hopefully we should come out of it very soon. Then the opportunities and then questions that we're pursuing presently, and then what we hope to get, what we hope to do post the COVID era. Next slide, please. So to give a form of background, our center is in West Africa. We run a more individualized program compared with Suraj, which is mainly community-based. We are one of the partners of Smile Train. I'm sure quite a number of us are aware of who Smile Train is. And then it's through this partnership that we've been able to provide speech services for our patients, which we are actually in our infancy, because we started the speech therapy services in our center in March 2019. That was last year. Next slide, please. So the way the program goes really is that our patients they have their repairs 1 year at 1 year of age, and then a post repair assessment, speech assessment at 3 years of age. But however, when we have patients who present after 3 years, they have a pre-repair assessment first, and then we have the surgery. Then 3 months after the surgery, we have a post-repair speech assessment for the records. Next slide, please. So the therapy programs are individualized, and then they are based on the target sounds that are identified during the assessment. And then after the therapy program, we now have a post-therapy assessment, and then the patients are seen 3 monthly for a year, and then subsequently we just call them in or via phone call to assess the connected speech. Next slide. So before the COVID era, the speech therapy usually takes place in a small room, and then it's self-contained. It's sealed from the outside to put out the noise, and then it's air conditioned. Next slide. Then subsequently, we have the therapies are scheduled fortnightly, every 2 weeks. And it's during these 2 weeks that each target sound activities are practiced to get the target sounds. Usually with each session, we have the patients coming in. They're usually young, and they come with their parents or their siblings and or friends. So when they come, we do have games together. It's usually so much fun to do that. And then the therapy sessions usually takes like about 30 minutes to an hour, depending on how the patient. Next slide. Next slide, please. Yes. Yeah. Also during the pre-COVID era, for patients who cannot make 2 weekly appointments, we use the telecommunication mode. And in this case, we would have a first physical clinical visit where an assessment is done. If we have enough time, we would also start the therapy for the first target sound that is identified. And during that first clinical visit, the minder, who can be the parent or the friend or an older person who comes with them, the minder is taught how to do a video recording using WhatsApp, so that the follow-up sessions can be sent to the speech service provider via the WhatsApp. And then when we now realize with the WhatsApp chat that the target sound has been achieved, then the client is brought back into the clinic for a documentation video. This way we reduce the number of times that the patient will need to come to clinic. That's during the pre-COVID era. Next slide, please. Then the lockdown started, which for us started in March. Initially, for the first 2 weeks, it was pretty acute. So speech therapy services were put on hold for the first 2 weeks. What we did mainly were to maybe make phone calls to different families. We have roughly about 25 patients. Practically most of them have phones that we can call to, and just to ask how they're doing, if they're keeping safe, and if they had some exercises or tasks that has been assigned to them, if they are coping with that. So this went on for about 2 weeks into the lockdown. Next slide, please. So when we realized that the situation was getting worse, then we now started looking more into expanding the scope of the telecommunication formats that we had before the COVID and try to extend it to as many patients as we can. That was limited instantly by the quite a number of patients not having the smart devices. They would have phones, but they wouldn't have the smart phones or tablets that would enable the telecommunication. Having access to internet was something else. Then even data, it was also something else. Though we now realize that in some situations, we could get the patients to, maybe they would have a neighbor who has these facilities, and then at a scheduled time, we would see them via the WhatsApp with the neighbor's device. So this is a present mode of what we're doing right now. Next slide, please. So post-COVID, we're hoping the lockdown, what I mean by post-COVID is when the interstate border restrictions has been taken out, the schools have resumed. So I think that's the normalcy we can hope to see in the near future. Post-COVID, what we hope is that we would have to lay more emphasis on the telecommunication channels. And then this will try to encourage more patients to use this mode, especially for the review and follow-up sessions. And we do know, because just about maybe 7 out of about 25 patients can afford presently to do this telecommunication formats. We are thinking that we may need to encourage our patients, even if they would have to solicit for this telecommunication mode via other people, even if they are going to be charged, then we will pay them stipends. So far we can have the opportunity to have that scheduled meeting that we would help them with what they might need to pay whosoever is assisting them. Because presently in our country, you can actually go to where we call phone booths, where you pay just little money in order to make a phone call. But in this case, it will be more like someone they know that has a WhatsApp app, and then we would see how we would help them out. So that's what we're thinking. And I am thinking that the scheduling of our patients will also have to be limited. Initially, when we have the patient coming in with the mother or the guardian, and then friends or siblings coming where we play games together, the number of people will have to be limited. Next slide. Also, when patients come in, we would also have to be screened at the entrance of our clinic, the temperature, and then hand sanitizers, and then wearing of face masks. But during this session, it's specifically, the patient would need to wear a face shield instead of a mask, whereby the cleft service provider would be wearing face mask, and then would generally maintain the universal precautions. These are plans for post-COVID lockdown. Next slide, please. The layout of the clinic, the one before that, please. The slide before this one. Yes, okay, next slide, yes. So the tools, we want to get more towards tools that can help some form of distancing. This, which is called an oral and nasal listener, we came across this in a publication by Kuma in 2011, and it's actually possible to use this kind of tool in order to assess for nasal emissions. And at the same time, it also helps maintain some form of distancing between the service provider and the patient. So where this particular one, the one I'm projecting, where we fabricated that from old stethoscopes and then the cover of hypodermic needle, and we're able to get this, which works pretty well for us when we tested it. Next slide, please. Then the sites where the sessions will be taking place also have to change. Initially we're using the air-conditioned room. We're tending more towards a more open place whereby the airflow can be directed towards an open window, and also have some form of distancing between the service provider and the patient by having a table in between. But I can see a challenge with this, especially when for adults, yes, this should work pretty well. But when it comes to children, it can be pretty difficult to keep them in a standstill point of a place and then do the therapy. But we'll see what we'll do with that. Next slide, please. So in conclusion, it is our hope that the pandemic would resolve soon enough, or we're envisaging that it's really going to task our capabilities. We're still thinking of what else we can do, and then it's still going to task our resources. So that's my reference for the ONL, and thank you for your time.
Thank you, Dr. Adeola. Very, very fascinating. You can see from the chat, people are already being sparked with some questions. I see some hand claps from Dr. Crowley. Yeah, feel free to again use the reaction button, use the chat feature to record some questions or comments. As we get our brains ready to travel, we're going to get on a plane, go from Nigeria all the way to the southern tip of South America, Santiago de Chile, where we have Karen Goldschmied, a really intrepid SLP from Calvo McKenna, a smile-trained partner. So she's a speech and language pathologist specializing in craniofacial conditions at Calvo McKenna, and a member of LACTIFA and ACPA. Smile-trained partner, again, as I mentioned. We're delighted to have you as well. So Karen, please take it away.
Thank you so much, and thank you for the invitation. I have to say from Chile, good morning. And it's nice to give a little bit of thoughts what we are dealing with in Santiago de Chile, and what are we heading towards. Well, just a little bit of general information. This is our country down there, this long strip. So this COVID has affected us a huge impact in health, in schooling, in work, in poverty. We're getting there now. We didn't have so much poverty being a South American country now, and in our days this has changed a huge impact. But to cleft, we have around 450 new cases per year, so it's a lot of incidents. And as we are a very centralized country, most of the patients are in the central region, meaning this metropolitan, the capital, the 5th and the 8th region of this country. Next. So this is our entrance of the hospital. This is a nice view of our capital, Santiago de Chile, with the mountain range behind. This was taken a couple of days ago. We have now winter time, it's rainy, so we have no smoke. And because of the COVID, there are less people in the streets. So this has helped a lot in contribution to have this nice picture and this nice air quality. So we're a public pediatric medical teaching hospital since 1942. We serve the eastern area of the greater Santiago, but also some complexity pathologies from all the country, meaning that's where cleft palate is included. And we have an average of 6,000 inpatients per year, and we have also outpatient clinics at the hospital. One of the questions that Hugh made me is what was before COVID, and I want to briefly go over this government program that I feel that all Chilean people are very proud of it, because it helped us to improve quality, to gather teamwork, and that the hospitals, they have to organize, not all hospitals. I know there's a lot of Chilean listeners now, and correct me afterwards, but I feel that we have only 5 main hospitals in Santiago area that are capable of treating these children. This means that we have now expertise and gained all the different actors of a team together. So we have a comprehensive care in Chile because of this program. So cleft lip and palate is one of these, and this means that as of July 1st, 2005, all children that are born with cleft lip and palate, they have by law the right to be treated well. including all the rehabilitation, not only surgery, till they get to the 15 years of age. Next. So I won't go through this, but this program has helped us to have this algorithm. So now this is by law again. So every child that has a cleft lip and palate has to be treated before the 15 days of delivery. That means if it's born and it has been made an interconsultation to our hospital, we have to receive that child not more than 15 days. So we receive the children very, very young and a young stage. So they have the possibility, for example, to use NAM advice or to be treated by speech language therapist regarding feeding issues. And this has helped a lot with feeding problems and gaining weight and be proper to the surgery. The surgery for cleft now has to be undergone by 12 to 13 months of age. So this has also helped us to have better outcomes regarding speech and less articulation problems. Next. I won't go to that. Downstairs, I put the web page where you can search this program. It's in Spanish. If you need help, I can do that. But it's very organized and it's written by all these experts that we're getting together to see which would be the best outcome for children with cleft, having studied, and we did that. Looking to scientific evidence to have which is the best care for these patients. So this was all before COVID area. Next. This was us with a coffee. We're Latin Americans. We love to get together and chat and have coffee in our meetings. So I feel this is going to change maybe for some time. But it helped us to gather all team members, to have nurse, to have administrative staff in this program. And this has meant that the children with cleft have access, opportunity, and quality of treatment. Next. So this was me prior to COVID. The first picture that you see there, this was in Mexico. We did a training program with help of Transforming Faces as well. We went to see Mari Carmen Pamplona, a good friend and interesting work. She does lots of camps, a little bit like Rahi. And well, children spend the night, even the night, and they attend camps for weeks, sometimes only for weekends, and we have group working together. So this is going to change probably, the group sessions. Let's see what's going to happen there. And I love the not yet Nettie. Can you go backwards? And the other two pictures is what I feel that I'm losing. I'm talking now about my experience. Cleft and lip palate speech is a characteristic where you have to use all the senses to facilitate learning progresses, and this has meant a little difficult for me now in these days that I don't have direct access to the children. I am very hands-on as pathology, and I love to work seeing the child face to face. Next. So what is telepractice? Is the delivery of these professional services by distance, by linking the clinician to the client. I don't like the word client, but to the patient, and clinician to clinician. But Asha also mentioned there in this brief advertisement is that we have to adapt assessment or intervention materials for the proper delivery of telepractice. And this is a huge challenge now in the future. Next. So I tried to search for telemedicine. Most of the papers that we have now in telemedicine regarding speech are more focused on adult pathologies rather than children. And I feel that I have to speak about Chile. Most of our patients are children now. We don't have as much adults with non-treated cleft problems. So it was difficult for me to find something that is in the literature. I found this paper from 2012. It was a study done in the US with Mexico, but I have to mention the number was very low, nine patients, and they tried to make or to feel if it was a difference by using telemedicine for evaluation purposes. And they didn't have a statistical difference between that. And also the important impact that telemedicine had on the family and on the children. And this is a paper regarding cleft lip and palate. So I just want to share it so you can go over it. Next. So this is me now. And again, we have lack of papers, lack of literature now. So this is a personal experience. This is nothing written. We have to write more in the future days about our outcomes and our impressions. But I feel it's more demanding for me, for myself, to make those changes. And also, you need to plan the sessions more in advance. There's less time for spontaneous interactions. And the parents, they have to have an active role, even as with younger children. You can't deal with a child alone with a laptop or a phone. And you see me all up there in the corner. That's how I feel, that I'm a little bit more backwards now and not more in the same level as the children. So it's a different kind of new adjustments that we have to make. Next. So what are my challenges, or what I have felt now using telemedicine? I most of the time use more the WhatsApp application. Some parents, they use Zoom as well, or meeting programs that we have. But in Chile, we have had a study like 2 years ago where they stated that for one person living in Chile, there are 2 phones. So actually access to phones is not an issue. That doesn't mean that they don't have access to internet or computer. But I have been using most of the time phones and the WhatsApp of the parents, and sometimes video transmission that aren't good enough, they may impact, but then again, you have to make some quick adjustments and try to do that. And so it's important also to mention that the parents, they have to be there, and the professionals, I feel, as we always talk, we have to be with a lot of knowledge about this, and more in our days when we are so far away, close but far away from our patients. Next. So, but there are benefits, and I don't want to be alarmist of this. I feel that telemedicine has come to stay. Actually, it did exist before COVID pandemic, so it's not new. It has been used, and it's being very widely used, but there are a few studies in speech, and I think that's one of the things that we could discuss, how we are going to prove that we are acting right and that we are having good results with our children, even if they're so far away. But it represents an opportunity, it's an easy access, it's cost effectiveness, and it made us to have a long-term follow-up for our children. Now, not talking about only speech, but in our hospital, medical staff, they're making phone calls and doing also telepractice to make a follow-up in those patients who were recently operated on. So it's a huge help. It improves standard of care. We still keep on trying to do this. Is us, our surgeons and our maxillofacial surgeon, Carmen Gloria, Claudia, and Loreto Castellón, having some chats and meetings. We're still trying to keep those. So telemedicine, it's not only meant for patients, it's also meant for us as a team. And I feel that like this meeting that we're having now, this is going to be in the future also part of our lives and educational programs. And we were going to have less face-to-face meetings. So I will miss the social part of those meetings, but it's also there for us to be trained, like I said. And just at last, the local characteristics related, we saw in all these presentations, the two earlier presentations, we're different, we have different access, we have different cultural contexts, clinicians are different. In each country, our language is different, our religion is different, so we have to consider all these aspects and to make studies that we could compare and we can compare further and give us the right path to work as best as we can. And I don't know if you all know Abdon. It's our Chilean adopted child. This is Mirta, my colleague, and myself. And I miss this. Latin Americans, we are very of physical contact, and you see up in the screen, this was our gradation from our first couple of children born in 2005 and a little bit earlier before that. And they were released from our hospital with all the treatment done. And you can see all the team members as well there. So this is Latin America. We are very from skin. I don't know how to tell that, but we miss this. And I think this is also a huge impact for our children, and we have to take care if we're going to promote telemedicine after the COVID area problem ongoing, or only for those cases that they don't have access or that they live far away from our main center. So I leave that open question. Thank you.
Listo. Gracias. Thank you so much, Karen. Very helpful. All right. Well, we've had lots to think about, and we only have a short amount of time for our discussion, but I do want to make sure we're adding in the voices from the people on this call. Please do, if you haven't yet already, just peruse the chat. So if you click on the chat button, you can see some of the discussions that have been ongoing already. But just as a quick starter, I mean, there was a question about the technology and even physical technology. So there was a question about face shields and masks and who should be wearing them and who shouldn't be. There's a question for you, Dr. Adeola, about the idea, what are some of the limitations if the speech therapist or whoever's working on speech is wearing a mask, even if the participant is not, and you think there's a safety concern there that both could be wearing shields as opposed to one with mask and one with shield?
Yes, actually, thanks for that question. It's something that I'd wondered about. During speech therapy sessions, there are both visual cues, tactile cues, and when during the session, the patient cannot see the speech therapist's lips moving and the manner with which they're moving, that can be a challenge. I was actually wondering what one should do about that. I'm open to the suggestions that may come from this discussion. I'm thinking, even if the therapist is wearing a face shield instead of a mask, it may subside. It might be okay if the distance has been put there, because whatever it's really the aerosol would hit the mask really, and then we are sanitizing as frequently as we can before touching, after touching. The sanitizer is there. So it's an idea that it's developing, and we hope to fine tune it.
Thank you. That's a great comment. I mean, I think, you know, these are the kinds of things that I think for us working in low middle income country contexts, you know, we need to be thinking about what are the guidance that we need. So you've asked a good question. Is it safe enough? And I think that is something that the world needs to wrestle with. So we give good advice around that. But again, that's how important that visual feature is for the therapist to be able to demonstrate. And you'll see some other comments in the chat feature. Suraj, to you, there was quite a few questions and comments about parents and parents, you know, availability with these community-based workers, etc. What are your thoughts on parent training or how parents can be engaged in this era?
So it is very difficult to do it now because we need to have a dedicated training program. There is a separate work which has been, we are in the thinking process. Parents should understand, and the language which we are using to the parents should be at a very basic level where they can understand, you know. So that's a very important point we are considering, but whether the parents are available to do this is what is very difficult, because they are willing to give the phone to the child and be happy that the community worker is handling. When we want them to be the facilitator and to conduct and all of that, it is a challenge. And these children are not new. They've already enrolled into the tele program. They were familiar with what is going to happen. We have not touched those children who have not sat in front of a tab and seen and followed instructions for a very long time. So that is a challenge. There is a plan to conduct small interaction sessions with family. You know, we just completed a dissertation where our part of the study got into the pandemic, where tele was also not possible because most of the fantastic devices which we have is with the community worker. It is not with the patient as such. So we cannot transport all the equipment, and all. Now we have the money to buy so many headsets, so many devices for everybody. So even tele with the CBRW as a facilitator is a very difficult work. Involvement of parent is the most important thing. And we work with a community where livelihood is more important than speech therapy. Speech therapy can wait, sit back for the next 6-8 months or however long, because they want to feed their children. They have to make their daily living. So speech therapy does not come into their direct value. So I really don't want to thrust my idea of intervention into them. So I want to make sure that we both buy in the decision together.
Thank you.
We will take whoever comes with us.
Thank you. Yes. So putting extra pressure on the parental relationship, and yet acknowledging that this has to be a joint venture. It's not, imposing speech therapy as a top priority if family nutrition, family caloric needs are the top thing. Thank you, Suraj. That's very helpful. And then one quick question for Karen before we get forward. Karen, I think you brought to the fore really the emotional aspect for healthcare providers, that this change is changing not only just, do we do it this way or do it that way, but it actually involves some of the joy, some of the real elements of evidence of impact that we've had before. How are you managing this particular element of this drain of having to change everything and potentially in ways that don't feel as encouraging in this COVID era?
I feel that if you just call the patient, just for the only purpose to say, hello, how are you dealing, this may have huge impact, emotional aspects, just to know how is their well-being. So just giving them a call, we still can keep this emotional aspect of our involvement with our patients. It's not only medicine, there aren't numbers. So it's there. I use phone to call them, but I feel that after this big problem, huge worldwide problem, I will go back again in-person treatment. I feel this is the best, and that telemedicine is a goal. We have it there. We have to use it. We have to know how to use it. But again, I think in-person will be still the best part of our evaluation programs and treatment program. So maybe for those that they don't have access to speech and language therapy in community, or that live far away, it's going to stay for those. But again, I feel we have, after this big area and this problem, we have to go back and make some of equilibrium, some adjustment.
Yeah, equilibrium between the new and the old, and what works. Yeah, thank you. Very good. Dr. Adeola, another piece that came out, I think that that you're bringing to the fore, that all three of our panelists mentioned, was new ways financially of thinking through. I mean, I was really struck by the idea of providing money to access WhatsApp does not mean buying an internet package or a new cell phone package, but even just working with a neighbor who might have access and figuring out financially how to make that work. Can you say more about just financially? And then again, there's some pressure obviously on us as NGOs to think about the flexibility that might be required to give people access to this. Can you say more about your strategy on that?
Yes, thanks you. As you said, it's just a strategy. The reality of it will only pan out when one actually does that. What we have been able to do is, it's not based on money. It's just a patient comes to that before the pre-COVID era. A patient comes to clinic. Oh no, I don't have that kind of phone, but my neighbor has. They will say, okay, at 2 o'clock. Maybe on Friday, go there, and then your neighbor connects with me. You give the WhatsApp number, and then you speak with your clients there, and you'll be conscious of the fact that it's the neighbor's facility that we're using. So just for a short period, we talk. But if we, with the post-COVID era plan, we're thinking would provide stipends if we're able to make such call. Now, how much we're going to give, that has not been settled, but it's a concept that we're working on. So you would meet someone who has the facility at so time, can I come? And if the person says, okay, that time is okay by me, or if not, then you get a scheduled time, and then they will tell us on phone when we can call, and then we'll have the facility. That's
Oh, fantastic. Yeah, I mean, obviously the level of complexity involved with navigating not only with patients, navigating with parents, and then navigating with neighbors, obviously it blows the mind. But if we have no other opportunities, I mean, I think these are the ways that we need to be thinking. So I really appreciate that creative thinking, Adeola. We've had a few other questions on the chat coming in. Felicity's wondering about the idea of, any barriers from government or management of data protection. Is there any challenges you're facing from your hospitals or from the government itself on how you're reaching out in these ways? Or is it at this point just you're sort of figuring your way out, and maybe some of these questions will come later? We'll go to Suraj first, maybe about that.
Yeah, you want to answer that question?
Sure, yes, or just have a couple of thoughts.
So this is our independent work. I think government does not have any interference on any of this, and this is a part of our work which has been committed, and the database is available with us, and the only thing is that the phone should be available with the family for us to reach, and if it is there, we are able to achieve the first contact with the family. And like Dr. Adeola said, this concept is very new. And the only good thing about this concept is there is some kind of commitment from the patient some kind of commitment from the patient side, because they are investing their time by giving the phone to the child to sit in for therapy. There is also indirect money they are investing in the session, which was not happening in the other sessions where they come, they get therapy, they get everything, they get travel reimbursed, everything. So there is more commitment from patient side if they are coming for regular sessions. So that is something which I see it as a very positive side in tele in my experience.
Very good. Thank you, Suraj. And I think that there is Kathy from Canada has offered just a quick note. We can circulate this on the website, etc. But that there is. Like in Canada, there has been medical grade clear masks, and then in the meantime, there's a clear mask transparent face mask they've been given authorization to import from. So an American company. Anyway, just say that these questions are being explored around the world. Canada is obviously working on a solution. Hopefully this will be helpful to others too as we think through, how do you not limit some of these real benefits of traditional speech therapy approach, like the patient being able to see you enunciate yourself in this COVID era, but without, at the same time, not compromising patient or professional safety. So obviously there's a ton more to say in this, but our hour is almost up. So I've got a few other things. Just a huge thank you to our three panelists, to Suraj, to Dr. Adeola, to Karen. I mean, we're just delighted. I think we got a really strong perspective insight. I'm seeing lots of clapping hands throughout the thing. Rama, I see you in the chat asking some very distinct questions too. We'll follow up with you, and I know that our panelists are keen to help, especially regionally and beyond. So we'll continue to talk about this. Now, if you enjoyed this, if this is something that you feel is really helpful to you, stay tuned. The Circle of Cleft Professionals is thinking and listening to you, and we have some big news to report shortly about a conference in September. I see Suraj smiling, a big smile. This is the advertisement embarrassment time. But in September, we're planning to have a conference focused on these very type of questions. You know, where practitioners from low and middle income countries can share some of their practices, some of the promising ideas and the questions that they want to pursue. And we can all gather, listen in, and try to present some real documentation of the way forward. This is a difficult time. I think we heard it in everyone's voice. This is emotional. This is challenging when we see patients and families not getting access to the care they need. So if you would like to continue the discussion in the meantime, Niti UC has pointed out the Slack discussion forum. We'd love to have your questions or comments to continue this there. That's also where you'll be able to find a recording. So if you didn't catch all the ideas, all the richness that we saw, then you can view this later, either in Slack or on YouTube. And if you want to keep up to date, you can follow COCP on Cleft Circle. And then next slide, please, Niti. Don't forget, a lot of these topics are brand new sources of research and innovation. And I think you heard from Felicity, from Debbie, from Trina and others, Kate, saying we need to write these things up. We need to figure out how to present them so they can be tested, so we can get that affirmation that we're going on the right track, that we're getting the results that we're hoping for, even under these constrained circumstances. So research and publishing is obviously a key element of that. If you'd like to know more about that, join us in July, where Dr. Christy McKinney, a real friend to cleft and craniofacial issues, will join us and lead us in a seminar on that. In the meantime, I'll remind you again, please, you in your email address, you will have received an invitation to complete this survey. It's taking people about 6 to 7 minutes. That's it. And we're really looking for every context. So in northern countries, in southern, east, west, we want to hear how your own practice is being impacted by COVID-19, what you see as a way forward, and if there are some great ideas or promising practices that you're aware of that you'd like to test out or hear more about. So this is really critical stuff. And if you could take 6 or 7 minutes, even right now, to fill that out, we would be delighted to hear from you. In the meantime, you can always get in touch with us at info@cleftcircle.org, and we'll get back in touch. And on behalf of Smile Train, Transforming Faces, the Circle of Cleft Professionals, we want to say thank you for joining us. And again, a huge thank you. I'll get my little reaction there. You can try it out too. A little hand clap for our dynamic presenters who really got us thinking well today. So thank you to everybody, and thank you for investing this hour with us today. Bye, everybody.